autom automatic translation. So go ahead. Thank you, Nick.
Great. Thank you so much. So the title of my talk today is going to be, Should I Operate? I have no relevant disclosures in terms of financial conflicts. So my objectives today is I'm going to define for everybody what frailty is. I think it's a very important term to know when you're deciding which types of patients to operate on and which ones maybe you should avoid an operation or wait, or come up with another option that may serve them. What prehabilitation is and does it help? So I'm going to present a couple CAT scans right now and patient presentations, and we'll see if this is something that you would or would not operate on. So patient one is a 68-year-old woman with an 8 centimeter by 12 centimeter incisional hernia after a hysterectomy. She has a history of diabetes with a hemoglobin A1C of 8.3, hypertension on 2 medications, no cardiac abnormalities, no smoking, no alcohol use, and her BMI is 42. She was a 78-year-old with a 8 by 10 centimeter hernia. Past medical history significant for MI 2 years ago with stents on Plavix. A former smoker who quit 2 years ago, but no diabetes, no hypertension with a BMI of 37. So both are patients I've seen, and trying to decide which one would be a better surgical candidate versus the other can be hard in deciding who you're going to operate and who maybe you want to optimize some things and get them in better shape before you offer a surgery. Another thing that I think about when I'm deciding about operating on a patient or not is looking at their CAT scans. So this is an example of 2 CAT scans of the same patient, and I just want you to pay attention to thinking about what features of their abdominal wall are important when I'm going to be deciding to operate, and what features do I really need to pay attention to outside of just defect width size. Comparing the previous 2 CAT scan pictures to these two, you notice hopefully that there's a significant difference in muscle density between the CAT scans. The places I like to look for this are in the paraspinous muscles and the size of obliques and rectus comparatively to the amount of visceral and abdominal fat. So when I'm looking at this CAT scan for this patient, I think this person has good musculature that I can keep up with, and there's someone that I think is decent to offer an operation. And you may be able to see, I'll anonymize the information as much as possible. This is a 70-year-old's CAT scan. So this 70-year-old has kept up their musculature pretty well, whereas if you just use an arbitrary age cutoff, if you're going to decide whether someone is a good candidate for surgery, it may not only miss a few people who would be decent surgical candidates, but you may operate on a few people that you shouldn't be. For example, when you look at these 2 CT scans, the CT scan on the left, or screen left, excuse me, is a 58-year-old woman, and the one on the right is a 70-year-old. So you can see that despite the age not being the most important thing, because these 2 patients are actually younger than the prior 2 CAT scans I showed you. So what I'm talking about here is sarcopenia. So sarcopenia is defined as massive loss of muscle mass seen with abnormal aging, or seen abnormally with aging, excuse me, often is a frailty. So when I'm looking at CAT scans, you want to look for the density of the muscle as well as how much fat infiltration into the muscle belly has occurred. When you see this kind of fatty infiltration into the muscle, you want to start to thinking about some type of prehabilitation regimen or routine to get these people in maybe a little bit better shape for an upcoming surgery. So let's talk about frailty. Frailty is a term that's really kind of growing in popularity in the surgical population. It started as something that was very hard to define, often with, 40 to 50 variables being necessary to really identify people who are at risk. So surgeons started looking at frailty and frailty definitions and tried to identify ways to find patients who meet this definition of frailty before you get to the point of an operation so that you can get them in better shape. This population has a high frequency of hernias. In the US, 350,000 ventral hernias are performed yearly, and over 40% of these are age over 60. So although I previously said age is just a number, frailty does occur more often in patients. So is it really just a fancy way of saying who's older? It's really this decrease in physiologic reserve giving rise to vulnerability that's separate from the normal aging process. So another way to put that is we're not just saying that this is just an old person who won't be able to keep up. It's that this person may do fine in the surgery, but their recovery afterward is going to be prolonged, more difficult, or be more fraught with complication, morbidity, even mortality. And it is different than the normal aging process. And I'm gonna talk about a few ways to help identify who is frail and what we can do to maybe reverse it. So how can we determine if the patient in front of you is frail? There's two kind of different used in surgery, this 11-item modified frailty index versus a 5-item. The 5-item has really been proven to be just as effective as the 11-item. So I'm just going to provide the 5-item modified frailty index for you now. And this is important to really stick to the definitions that we talk about. So hypertension requires. So if someone has a remote history of hypertension but is no longer on medication, they don't meet this criteria. But a patient on anti-hypertensive medication is item 1. Item 2 is diabetes. It does not matter if it's controlled with medicine, well controlled or not. The presence of diabetes is a risk factor for frailty. COPD or leading up to 30 days before the procedure. Again, keeping in mind our definition of frailty is that we're trying to identify a group of patients who have less reserve and an abnormal process of recovering and getting ready for surgery. So COPD or pneumonia within 30 days of procedure, their overall functional status. Are they living at home alone, taking care of themselves, doing their activities of daily life? Do they need a part-time caregiver, a full-time caregiver? Are they in a nursing home? People who are not taking care of themselves on a daily basis fit this criteria for frailty. And congestive heart failure, usually with an EF of under 50 is the definition, but diastolic heart failure can also fall into this category. So the 1-year mortality for any non-cardiac procedure, this includes orthopedic, abdominal procedures, general surgery procedures, the hazard ratio for 1-year mortality, even after adjusting for age, sex, neighborhood income quartile, which is a surrogate for kind of financial status, and procedure type, was still a hazard ratio of 2.23, even after adjusting for all of these. And interestingly, this increased mortality was especially high in the early postoperative period. So there was a steep increase in mortality in the first 5 days post-op. And then it kind of leveled off once you got to around day 90. Then they returned kind of to the normal range for the average patient. The incidence of frailty is very common. If you are operating on an 80-plus-year-old, 40% of them meet the criteria for frailty. It's, as I said, it's something that's being studied kind of across different specialties and fields. We have these are some of the studies, and I have footnotes at the end, which I can provide for people. But these are some of the studies that are coming out that are talking about this and trying to identify ways for surgeons to be more aware and to spend more time thinking about frailty. So it gets back to this question, would you operate? So if you're seeing, that 68-year-old woman, if we go back to the first case we were talking about, who's a hypertensive diabetic with a BMI over 42, you're starting to see some signs that maybe there are some things that are going to make me pause that this patient is at an increased risk for complication. Each point on the 5-point modified frailty index scale increases your risk of a clavidin complication by about 1.5 compared to the average population. But the problem is one of the problems with hernia is that most risk stratification tools are actually poor predictors in ventral hernia repair. The ACS risk calculator, which I'm not sure how much is used in this group of surgeons, is a very nice tool that can be used for a lot of good cases to predict mortality risk for patients. When you're trying to decide what are the chances of complications, what are the chances of morbidity, mortality, et cetera. Unfortunately, one of the things it's very poor at is doing that risk stratification in hernia cases. I'm not sure why exactly it does a poor job, but when they look at the accuracy of it in specifically hernias, it's worse than other types of abdominal surgeries. So adding this frailty kind of modified index into your workup can help you decide who we should operate. And so what we want to do is, what can we take a frail person to a less frail state? We want to identify those patients with modifiable risk factors that we can improve. So which of these factors can we improve for patients, and how do we do it? So at the end of the talk, I'm going to talk about some strategies for diabetic control, some strategies for weight loss and functional independence status. But really what this all gets down to is prehabilitation. Prehabilitation is this idea that we want to get our patients in good shape for the surgery so that their procedure and their recovery can actually help us and be better by doing some work beforehand, instead of just saying, you come to the OR, I'll take care of the surgery part, and we'll just deal with the recovery after. It's a more proactive attempt to improve the outcomes in your patients and hopefully make the surgery and recovery an easier process. So why do we care about this? We care about this because anything that complicates a hernia surgery or leads to increased recurrence increases cost to the hospital system, to the medical system, and to patients. So an elevated BMI. So this is a BMI over 40. Has an odds ratio increase of 1.64 for any complication and a 1.67 odds ratio increase of serious complication. Insulin-dependent diabetes, 1.34 and 1.51. So this is diabetes usually with a definition of a hemoglobin A1C of 8 or greater, and then that can be more or less strict depending on your personal preference. Not only do the risks of complications, especially serious complications, increase, but the costs go up as you're doing this. Median additional spending for these modifiable risk factors can range anywhere from $500 to $3,000 per patient for any complication. And when you talk about serious complications, this gets us up to $20,000 because usually you're involving ICU care, further operations, things like that. So the cost of this problem has a high magnitude of cost. And as surgeons, we can do things to reduce this cost and to improve the outcomes for the system and for our patients. One thing that's relatively important to keep in mind is that hernias have relatively high complication rates and have relatively high rates of reoperation. There's been a number of changes in the US related to this. And one of the things that's recently being studied is how common is hernia recurrence. And there was a recent meta-analysis that came out, or that looked at not meta-analysis, excuse me, a recent study came out looking at the ACHQC database, where they found that hernia recurrence can be as high as 40% at 10 years, even when mesh is used in certain patient populations. So hernia repairs in general have high complication and high recurrence rates, with 30-day readmission rates of upwards of 5%, which is pretty high for most general surgery procedures. Surgical site infection and incidence rates are 13%, and recurrence rates can range anywhere from 5 to 60% depending on the type of hernia and the study you're reading. Peristomal hernias are notorious for having complications and issues in particular. This is a table from one of the studies I had mentioned before, looking at these risk factors and the additional cost and the spending required to fix it. So as you can see, smoking, fourth quartile BMIs, this is a BMI of 40 or greater, has all of these increased risks and increased expenditures compared to if you can get away from doing any of these complications. So really paying attention to these modifiable risk factors and identifying your patients who you think are going to have more complications and more risk is a really important way to have an efficient practice to get patients out of the OR and out of the hospital in good order and to keep your costs down. So this is a really interesting study where they looked at the costs associated with modifiable risk factors in ventral and incisional hernia repair. This is from University of Michigan, and this is the table that I just previously showed you. And BMI in the fourth quartile, which should be the easiest of the modifiable risk factors to make an impact on, had the largest impact on postoperative spending and complication rates. Smoking also fit in. Inappropriate alcohol use led to more complications, and uncontrolled diabetes. So these are recommendations that this group came up with. They recommended weight loss for patients with a BMI greater than 40. If that required bariatric surgery or medications, they said that you should pursue that before hernia repair. Strict diabetic control with referral to an endocrine specialist if the hemoglobin A1C is greater than 8, because we want those numbers to be 8 or lower. I actually use a number of 7.2 because I like a little stricter glucose control, but anything less than 8 is satisfactory. And as best as you can, they're recommending smoking cessation 30 days prior to surgery. Now, the smoking thing for inguinal hernias, for small umbilical hernias, has less of an impact. We're talking about the patients that you're going to be doing major myocutaneous rearrangements, either with advancement flaps or large open procedures. Those are the ones who you really want to focus on the smoking cessation. And you really want to focus on it 30 days prior to surgery. You get the maximum impact if they have stopped smoking 30 days prior. So one of the things that is often the most challenging is how do you get people to stop smoking? It's one of the hardest things to do. And then on top of that, when people stop smoking, they tend to gain weight. So getting to patients to quit smoking or want to quit smoking can be very difficult. This study looked at 3 interventions in particular. One was at the visit, they just advised the patient to quit. What they found is that in a control arm where they didn't mention any of this, in the study period, only 2% of patients would quit. But if a patient was advised to quit by their doctor as a recommendation to improve their outcomes of surgery, they found they got a 20% patient buy-in in terms of quitting smoking. In intervention number 2, they gave advice at the visit, and there was a follow-up phone call with a staff member to remind them about it and to offer them more support in their efforts to quit. This increased their quit rate to 23%. And then intervention 3 was they actually had an outpatient in-person follow-up with a specialist who has tools, reading literature, medications, many things that can help people quit. And what they found is that actually found a 64% quit or reduce their smoking prior to surgery. So one of the most effective strategies to get people to quit smoking is actually frequent follow-up with the patient and trying to set up a program in your system where you have a specialist who has dedicated resources for patients to quit, and you give them an opportunity to meet in person to discuss it. So what we know from a number of studies for not specifically hernia is that prehabilitation can reduce overall and pulmonary morbidity in patients undergoing abdominal surgery. I've been talking about prehabilitation, but what does it actually mean? In this meta-analysis, they looked at a number of different studies and just the variability in what they meant by prehabilitation. As you can see at the top study, this was a 3 times a week for an hour where they did aerobic and resistance training for 6 weeks prior to surgery. There was no intensity target. They didn't measure anything. They just had people go and work with a personal trainer or a physical therapist. And there was no control or watching from the study investigators. In the next study down, they did 6 weeks of 2 to 6 times per week, 2 to 4 weeks of twice weekly supervised sessions. So as you can see, there's a ton of variability in what actually was done when we say prehabilitation. So I'm just going to give you a sense of what I do in my practice. The ACHQC is the Abdominal Core Health Quality Collaborative. It's Mostly surgeons from North America and a few from Brazil come together to kind of pool resources to kind of see if we can improve hernia care. And it's one of the databases that a lot of hernia surgeons are using for a lot of these papers coming out. And one of the things that they like to talk about are two particular tests that I'm going to talk about. One is called the get up and go or timed up and go test. This is a very easy thing to do in your office, and I do this with my patients who I'm concerned about frailty or potentially poor postoperative outcomes. First thing you do is you have your patient stand up from the chair without pushing off with their arms. So you ask them to stand up, walk around an object about 10 feet away, and return and sit down, and time stops as they sit down. This should take 15 seconds or less. If your patients are not reaching that milestone, this is actually homework and something you can give to them to have them do at home and then bring them back and retest them. The 6-minute walk test is something that you can do in clinic. You basically have the patient walk as far as possible, not as fast as possible, for 6 minutes. Breaks are allowed and basically just include resting against the wall. They should not sit down and stop, but you should encourage the person to get back to walking as soon as possible. Try to set up a known distance, 20 feet, 50 feet, whatever you can do in a hallway or in the outside hallway outside your clinic, and have the person walk that distance and measure how many times they can do it in 6 minutes. Try to set up a cone or an object that they can walk around, not just a wall they push off of. There's no goal per se in terms of if they meet a certain distance criteria, they are not frail. What you're really trying to do is establish a baseline to see how well they can do it and how far they can get. Repeat this testing 1 month afterwards to see how their training has gone. So those are some of the tests that I'll do in clinic to see how much prehabilitation I think a patient will need. If they do poorly on both of these tests, I'm going to give them some strategies to go home with to hopefully improve their performance on these tests. One of the things that's a very easy thing to do is work on strengthening inspiratory muscles. Essentially, you teach them how to belly breathe. You have them lay down on their back with their feet on a pillow. Take a deep breath in through their nose, letting the rib cage widen and stretching their abdomen out. They should put a hand on their belly to feel the abdomen almost inflate. And then they breathe out from their mouth gently and slowly, not forcing it out. So it shouldn't be an audible exhalation. And then they should feel how their stomach retracts back in. In the exercise I'm about to talk about, this is a basic kind of guideline or criteria for how much of these exercises you're going to have your patient do based on their current fitness level. It's very important to assess that current fitness level before you start these activities, as you don't want to take someone who's very frail and make them do a lot of activity that may push them too far and create an injury. These are some of the tests you can do, basically sitting in it, going from sitting to standing and back and forth, doing ankle pumps while laying in bed, just flexing and extending your foot. A gluteus stretch, basically you just squeeze your buttocks together, holding for 5 seconds and then releasing. And then while supporting yourself, holding a chair, doing heel raises. You can also sit in a chair for seated knee extensions, squeeze your shoulder blades together, do shoulder rolls, and contract your pelvic floor muscles with your breath. So these exercises are not particularly physically demanding. So even your frail patients and your older patients can do very basic forms of these. And you can show the patients in your office how to do them if you have enough time, or you can send them home with written material. These last two are a little bit more complicated, especially the lunges. You should really only have someone who seems physically fit enough to do it, do the forward lunges. But again, kind of having patients be aware of their breathing can be something that's really helpful as they are preparing for surgery. So we know prehabilitation works, but sadly, there's very little evidence for the exact optimal approach. So try to tailor your approach to each individual patient. And as you're doing weight loss, or you're doing smoking cessation, or you're doing diabetes control, or they're doing these exercise and functional independence training, have frequent follow-up. Try to have them come back and see you once every 2 months, every 3 months at least, so that you can check in on their progress, and it kind of gives them a little motivation because they don't want to let you down. So in my practice for weight loss, some of the strategies I give people is limit portion size, and an easy way to do that is to ask patients to just put their fist over their food, and everything should fit under their fist if it's going to be a cup. So you just have them put their fist over their food portion, and they should just eat only what fits under their fist. No eating 3 hours before bedtime. Carbohydrate heavy meals should really be put early in the day, and protein heavy meals at the end of the day. And the first time someone feels hungry, advise them to drink a big glass of water. For exercise, follow the recommendations I discussed from the ACHQC, but try to build an exercise regimen based on the patient's current fitness level. And these are my references.
Thank you very much, Nick. It was very clear, very concise. So we have some questions here, and there's one question about what do you do besides bariatric surgery to weight loss, but you have already answered it. And the next question is, let me search for it. Do you make any nutritional assessment before surgery?
Yes, I usually check an albumin level, a prealbumin level, a transferrin level, a CBC, just to look to check. I'll intervene on anybody with an albumin of 3 or less. You want that protein stores to be high, and I'll usually recommend they start some type of protein shake supplementation for a month before the surgery.
Great. Do you usually get some help from nutritionists? Or
Yeah,
just
depends on the resources of the patient. That's why I kind of like to have some ammunition in my back pocket, because not everybody has the time or extra money to go see a nutritionist all the time. If a patient asks for it, I'll certainly refer them to it. And I think that can really help, especially in patients who have binge eating disorders. It gives them a little bit of structure to avoid those habits. You know, the person who likes to eat a bag of chips at night before bed, that's the person that's going to have the hardest time losing weight.
Yeah. The next question is, do you have any strategy or protocol that you use in your clinic so the patient who smokes stop smoking, besides the follow-up or the watchful follow that you already described?
Yeah, so I'll prescribe in certain patients who I think are reliable without a psychiatric history. I'll prescribe Wellbutrin. I've prescribed people nicotine patches, gums. Nicotine has its own potential downsides, so nicotine replacement is better than cigarette smoking, but still has its problems. There's some theory that cigarette smoking. Well, in terms of if you had to, like, if someone can't get off any nicotine product whatsoever, and you have to do an operation on them, it's better for them to be on like a nicotine patch or gum than cigarettes, is what I was trying to say.
Okay, the next one is, some people would rather operate on people who are still smoking and not then have the risk for strangulated hernia. What's your opinion of this? Because we have, in 2023, I think, a large study that the conclusion was it doesn't matter if the patient is smoking.
Yeah, I think it depends your approach. If I think I can do a minimally invasive procedure, I care much less about cigarette smoking. That study, I don't like that study very much. I know it's kind of cherry picking, but I've been mentioning the ACHQC. One of my biggest complaints with that database is the amount of bias that's potential in their data is huge. So I think there's very good evidence in a number of other fields that cigarette smoking increases all-cause morbidity. And inguinal hernia, I think it's very well proven that it's safe to proceed with hernia repair and inguinal hernia. Someone with a small umbilical hernia, again, I don't think there's that much of an issue. But when you're talking about making skin flaps, when you're talking about doing transverse abdominis release, external oblique release, when you're disrupting major vasculature, you're then relying on the microvasculature to keep everything else alive. And those are the people that fail with cigarette smoking. Those are the people who get the infections because they can't clear debris out of their abdominal wounds. So if I have a person who's smoking cigarettes with a 10 centimeter by 13 centimeter hernia defect, their risk of strangulation and incarceration is extremely low. So I think that that's a person that you would say, okay, I can wait for this person to stop smoking cigarettes so that when I make my big skin flap, I'm going to have less skin necrosis, less wound complications. Someone with a 3 centimeter defect that has a loop of small bowel in it, I'm probably doing that minimally invasive anyway. So my concern with wound complications, which is the major driver for why we don't want cigarettes, is much lower. So I'd be much more willing to operate on that person smoking cigarettes.
And the last one, do you have some suggestions of risk scales, or what do you use in your patients that has more weight in your decision making?
In terms of like risk modifiers and
Yep.
like morbidity, yeah, I really don't. I don't have a like published tool that I use. Because I don't think that anything exists works particularly well for hernia. So I use this frailty index, and I use kind of their overall functional status as my main drivers for determining kind of safety to proceed with surgery.
Okay, I think someone sent Alex one last question, and he's going to
Yeah, let me just read it in Spanish. Me preguntan que si usa espirómetro o algún método medible para valorar que la terapia pulmonar o que el de tener el hábito de fumar le ha funcionado. Nick, someone asked if after after smoking cessation, do you think it's convenient to perform any sort of pulmonary function test in order to test, I mean, whether their pulmonary reserve for function is better?
No, I don't feel the need to do a pulmonary function testing unless someone is on oxygen coming into my office. I really think that's where that 6-minute walk test is really useful in that patient population, because they're the ones that are going to really stand out. People with cardiac issues, then the people with respiratory issues, they're the ones who really, really struggle during that test because they're not used to going for that length of time. So they have to take frequent breaks and stops. So that can be a really good kind of surrogate measure for that pulmonary reserve.
So that'll be it. Thank you, Nick. Thank you for joining us. Thank you for your time. It was a pleasure.
Well, thank you so much. I feel really honored to speak to all you, and good luck. And I apologize. I didn't put my email, or phone number up there, but Alex has my phone number and email. If any of you want to correspond further or ask me any questions, feel free to reach out. I'd be happy to talk more.
Thank you, Nick.
You.
Bye-bye.
Everyone.
Bye.